That was great. Thank you very much for synthesizing a lot of material. So I just would suggest sort of a small qualification, which is that I think one of the major concerns about whole genome approaches to newborn screening is, in fact, the finding of incidental findings. So I think that's quite important to call it that, because there's a framework for research upon which we can base our discussions. I would say that conventional newborn screening is not incidental, it's unanticipated findings, and that it's a little bit different. So just to suggest that qualification. Thank you.
I actually, if I can speak in two. The newborn screening results, what you can find, blood spots, and if there's movement in the direction. Second, isn't there something fundamentally different about parental informed consent when we're talking about consent to diseases that might be late life diseases revealed at the screening stage, or when we're talking about storage that will extend beyond the age at which an individual is an adult and could keep things private even from parents? And if so, what kind of thinking is going on about those ethical issues?
I'll answer I'll try to answer them in reverse order. First of all, I published an article in 1992 at the Houston Law Review in which I strenuously argued for the need for parental permission for newborn screening. So I am a lawyer, and I am not, and I can tell you that Korn must not have read what I wrote. And I've written several other articles too by the time their statement came out and said that parental permission ought to be required. I think the issue of biobanking is actually a separable issue, and from the issue about what parents need to be asked for. I am way past my eyeballs in biobanking issues, as well as in newborn screening issues. I think parents ought to be asked about this. I recommended it in 1992. The AAP task force in ACMG task force in 2000 recommended that parents be educated in the prenatal period. I'm glad to hear it's finally happening. And so, so there's a lot that can be going on here. I personally am I would just raise for your attention, there's a wonderful set of articles in January 2013 in the Hastings Center report that sort of argues for the fact that, if we require ethics for informed consent for all epidemiologic research, and if we require informed consent for every type of quality improvement research that goes on in the healthcare system, it will be a terrible thing, a terrible thing. And so now, to go back to your question about whether law enforcement has access to these databases, of course they do. Now, and in fact, it's sort of hard to build. In fact, healthcare institutions, they can get protection for databases from, at least some protection from access by law enforcement. But HIPAA actually allows access by law enforcement to anything that's in the electronic medical record. So, I mean, and the fact of the matter is that if you ask people what they think about using DNA to identify criminals, they're pretty happy about it. Twyla Brace is out there, I think, uniquely in the world, but I think pretty uniquely in the world. But I can't imagine a legislature that would pass a law saying that law enforcement can't get access to these samples. Can't imagine it. It's just politically untenable. Bartha's straining in the background, so I'm sure she'll have something to say. But I think these things are really complex. But in Sweden, when the killer of, what's the name of the person that the former prime minister was killed. And her murderer was identified using a newborn blood spot. You know, the people in Sweden were pretty doggone happy about that. So I think it's more complicated than what Twyla says, considerably more complicated. And I think the issue about genetic exceptionalism, about how we think about biospecimens, there are a lot of issues around that, but the attack on that is also an attack on epidemiology. And boy, that is a big problem.
Bartha Knoppers, Center of Genomics and Policy, McGill University. I'm going to quote you, since you asked a lot of questions, one of the answers that you suggested in a recent article in the annual genomics review, annual review of human genomics, sorry. One solution is to, with Tarini, by the way, one solution is to preserve mandatory screening for disorders which meet the standard of direct benefit to infants, but require parental consent for screening where the direct benefit standard is not met. However, this tiered approach raises concerns that parents may misunderstand the difference between mandatory and voluntary screening and then may choose to forgo screening for mandatory conditions.
Yeah. Thank you. Thank you for raising that, and I think that Beth and I took that as also a lesson from Ellen and Lainey Ross, who've also suggested this idea that maybe it's time, as we integrate new technologies, to think about these things as a tiered system, whereby parents would have a chance to get educated about secondary tests or genomic tests, to do two things, to allow this technology to expand newborn screening to include more conditions, to help kids for conditions that just wouldn't have been possible before that, but protect the core values of newborn screening in a way that allows states to do what they've done for 50 years in a really, really good way. So I appreciate that.
I just have a quick add-on here, which is that Anne Marie Como, who is sitting here in the room, actually did this in Massachusetts, where they actually piloted part of the disorders screened by tandem mass, and managed to get informed consent and have people make decisions. So I just want to say that not only is it possible, we actually have evidence that it can be done.
We have a question from the live stream, and I think it's a question that's come up, but it'd be great to see you guys take a stab at answering it. So if whole genome sequencing were to be part of the newborn screening programs, who will pay for the test? Is it parent out of pocket? Is it the public health funds? Because, you know, there's so many of those. And secondly, who will pay for the medical management of the care, particularly for late onset diseases that aren't immediate or life-threatening? So if you guys could take a stab at that.
Well, you know, those are really interesting questions. And the way it works in most states is that there's some public health support for it, part of it, but most of it's paid for by a fee that's charged by the state, which then goes to pay for the system. One of the things that's awesome about newborn screening, and I can speak primarily in the state of Tennessee, is that fee actually pays for substantial follow-up. Some states pay for follow-up care, many don't. And all of this is a result of the fact that we don't have a single-payer universal healthcare system in this country. If we had that, we wouldn't have to ask or answer those questions.
Any other?
I would also add the need for genetic staff would have to be increased. So a lot of public health departments do newborn screening without even genetics involved. And so either you'd have much more referrals to genetic centers, which there's not enough geneticists to keep up with that uptake, or you'd have to employ a lot of genetic counselors at health departments to try to help with that data, which is going to increase costs.
Lastly, I'd also just like to say that I've heard a number of proposals or people talking about what happened before tandem mass was really kind of universal, where some states had a core set of conditions that were paid for through the kit fee, and then parents could opt for a secondary panel that they may pay for, or see if their insurance company can pay for it. And I could imagine, I've heard people suggesting the same thing with genomics, that you would have the core newborn screening program and then parents could opt in for paying for a separate analysis. I think that raises a lot of equity issues. I think one of the best things about newborn screening is that it's universal. Parents can access this, and I think the idea of creating a system by which parents would be able to pay for this raises a lot of issues around health disparities and access to these technologies, which is inevitably going to be part of our conversations about genomics anyway, but I think clearly would happen in this case as well. So.
I think someone had a question.
Nope.
Joe McInerney from the American Society of Human Genetics. Dr. Clayton asked the question almost rhetorically a couple of times, is it worth it? Is whole genome sequencing worth it in the context of newborn screening? And I guess I'd want to ask, worth it for whom? I'm not sure we've given that sufficient consideration. And I'm just reflecting back on the history of some other debates. For example, the introduction of cystic fibrosis screening or testing, prenatal testing, and also direct-to-consumer genetic testing. We kept saying as a community, it's not ready, it's not worth it. It's not ready, it's not worth it. And the public kept saying, we don't care, we want it. And I wonder if we're not dealing with an analogous situation here. Not that I have a solution to any of this. I'm just wondering if it's ultimately going to come down to what the public wants and we just have to figure out a way to do it.
I think that's a great question. That's why I made the point that this is about science and politics and ethics and how those come together and how we're going to think about that in a society that's trying to think about how to deal with limited healthcare resources and how to think about comparative effectiveness and how to think about demand beyond means. But I certainly meant to highlight, and thank you for that question so that I can do so more explicitly, I guess, that there's much more at stake than the science, much more, and sort of figuring out how this is going to play out politically, ethically, all of that is actually very much in play. Thank you, though.
I also think it's an interesting question because you're talking about direct-to-consumer and cystic fibrosis prenatal testing, but they're not public health dollars, and so who pays, I think, is the question for that. Because if the public wants it, it doesn't necessarily have to be in the newborn screening setting. It could be at the pediatrician's office, and so that's a whole nother ethical debate. But the question is who's paying, where is it done? It may happen, but does it happen in the newborn setting paid for by public health dollars is a question for that too.